Okay, good morning, bonjour. Let's begin. We have a very full agenda, and I'm keen to learn from our three speakers and my co-moderator this morning. My name is James Milner. I'm a professor of political science at Carleton University here in Ottawa, Canada, and I have the real privilege of being the project director for LERRN, the Local Engagement Refugee Research Network. LERRN is a partnership between researchers, civil society partners, and refugee leaders in Canada and other parts of the world, but especially focused on the needs and opportunities identified by our working groups in East Africa and the Middle East. Through research, training, capacity building, policy engagement, and public dialogue, we're working to better understand and enhance the role of civil society in the functioning of the global refugee regime, especially in pursuit of protection and solutions with and for the displaced. I'd like to begin by acknowledging that the land on which I reside and on which Carleton University is located is the traditional and unceded land of the Algonquin people. Now, I say this not just as a formality, but I say this out of deep respect, in recognition of my status as a settler Canadian, and in recognition of the fact that the questions of dislocation, dispossession, inequality that we discuss today are so very much part of the history of this territory. And this acknowledgement is especially important today as we as Canadians continue to grapple with the news of our history and with the continuing journey of reconciliation on which we are still going. Let me say now how delighted I am to welcome over 100 registrants from around the world for this final webinar in the LERRN-IDRC Webinar Series. This is the 7th webinar that we have hosted since October, with more than 700 attendees from over 40 countries, engaging in topics ranging from refugee leadership, refugee education, to host community relations and proposals for Canadian and North American leadership in the development of a more responsive and effective global refugee regime. A central theme through these webinars has been the critical importance of learning from the knowledge and perspective of refugees, displaced persons, and researchers in major refugee hosting countries in the Global South. Again this year, when UNHCR, the UN's refugee agency, released its Global Trends report, we were reminded that 86% of the world's refugees and displaced persons are in the Global South. Yet more than 90% of the most cited and most influential research on forced displacement comes from researchers based in the Global North. We need to do better and to learn more from those with the most intimate experience of the phenomenon of displacement and the context within which it occurs. Our last webinar was specifically on the topic of the localization of forced displacement research. The report and the recording of that webinar is available on the LERRN website, which you can access through the link that's just been posted in the chat box. And on the occasion of World Refugee Day, this past 20th of June, I was delighted to publish a blog with our invaluable colleague at IDRC, Rula El-Rifai, in which we reflected on the importance of localizing forced displacement research and the lessons we have learned from our collaboration up to now. You can access that blog through the link that's in the chat box as well. So today's webinar is a very fitting culmination of this series as a whole. We have a fabulous group of speakers to help us engage with the question of forced displacement and health in the context of the pandemic, localized responses to COVID-19's impact on refugees, IDPs, and communities living in chronic displacement. I'm also delighted to share the moderating role today with Montasser Kamal. Montasser is the program leader for health research partnerships at IDRC. Montasser brings a long record of experience on issues relating to global health and health policy, and a proven record of amplifying the evidence produced by researchers in contexts of displacement and fragility to affect change in global policy and programming, especially in the areas of forced displacement and refugee health, sexual and reproductive health and rights, health system strengthening, and the political economy of health. Join the conversation on Twitter with a hashtag Health for All and by tagging learning. I'll be curating questions from social media in the second half when we have the discussion time. We hope you enjoy the webinar wherever you are. I hope you're safe and well. Thank you for joining us. And now it's my real pleasure to turn proceedings over to my co-moderator, Montasser, for some words of introduction. Montasser, over to you, please.
Thanks so much, James, and welcome everyone to this final webinar in the series. It's my pleasure to be here with you. My name is Montasser Kamal, the program leader for the Health Research Partnerships at the International Development Research Center in Ottawa, Canada. And Ottawa is where the city is built on the unceded Algonquin Anishinaabe territory, and the people of the Algonquin Anishinaabe Nation have lived on this territory for millennia and continue to enrich our lives, and their culture and presence have nurtured and continue to nurture this whole land and our lives more specifically. Now, as James mentioned, a few days ago, June 20th was World Refugee Day, when the world normally reflects on the millions of people around the world forced to flee violence and persecution. And every year, many people hope that the number of refugees goes down, is less and more settled, more peace, but that is unfortunately not the case. UNHCR's latest annual Global Trends report shows that despite the pandemic, which you'd have thought would have slowed things down, the number of people fleeing wars, violence, and persecution and human rights violations in 2020 rose to nearly 82.4 million people. That's a further 4% from already the high numbers in 2019. So these numbers include 26.4 million refugees, 48 million internally displaced people, and 4.1 million asylum seekers. In UNHCR's words, behind each number is a person forced from their home and with a story of displacement, dispossession, and suffering. And that's what we're hoping to bring today, really the stories of the experiences, not just the numbers, the stories and lives of these people, and especially in relation to their interactions and with health systems and their health status. Many of these conflicts and displacement implications are also intergenerational, resulting from decades of displacement and uprooting, and have long impact on the health of millions of displaced populations everywhere, as we are indeed witnessing now and coming more clearly in the Canadian context in the lives of Aboriginal and First Nations. While peace is positively associated with health, the reverse is true. The denial of peace and home is a threat to the health and well-being and life itself of tens of millions of perpetually displaced populations. In all these situations, it's critical that governments and international organizations have robust plans in place that prevent disease, treat people, and support health services for life events such as pregnancy, births, and deaths. We continue today to experience COVID-19 pandemic. No country has been untouched by it, it is sort of, despite the hardships, life in conflict, emergency, and fragile situations goes on. People are born, married, divorced, die, and in these contexts, health services are vitally important, even as significant strains are placed on these systems because of COVID-19. Displaced populations and the populations with whom they live and share living space are at high risk of acquiring COVID-19 because of their living conditions that make it impossible to practice what many of us are privileged to have, physical distancing or access health services. And refugee women and other particularly vulnerable populations are most affected by this because of the interruption of services. These hazards are faced by displaced people in conflict, emergency, and fragility, prevent them from accessing even basic services, and which has put also as a result of COVID-19, which has put further strain on health systems and displaced populations in particular. Bridging these shortfalls bringing health systems to the displacement debate is a vital step towards the decade of action towards sustainable development goals. Yet one of the most important challenges in this context is the rush to rely on ready-made solutions. There is usually kind of such a sense of urgency that everything has to be done in a rush, in the short term. But in such settings, the short-term actions are really short-lived, and that is really what they are, and end up wasting valuable resources because they're not localized and they're not contextualized in most cases. I'll just share at least, there are at least three, quickly, there are at least three implications to this mode of thinking, this urgency and short-termism. First, the local context is ignored. For example, insisting on facility-based services when women are not allowed to leave their homes is pointless because the local context is ignored. Second, sociocultural issues are glossed over in these short-term kind of quick fixes, and gender relations are then ignored or overly simplified. And there are many examples of this. I won't even go into the details of how violence against women has increased because of COVID-19. The third implication of this short-termism is that in the context of COVID-19, for example, the broader public health implications are ignored. So, giving vaccines to citizens and not to displaced populations in a country is just one glaring example of how this inequality and inaccess to services has a broader public health implication that is not taken into account in these short-term plans. In these contexts, research takes the back seat usually, unfortunately, or becomes excessively localized, meaning that the same sites, camps, locations are excessively researched with others and other people remaining completely ignored. The speakers today will speak to us about how health systems respond to the needs of displaced populations, including during COVID-19, and show examples of how research can help build better long-term responses to these needs. Thank you very much, James, for the opportunity.
Thank you so much, Montasser, and it's such a joy to have you here. Montasser will be introducing the second round of questions that we're going to pose to our speakers and offering some concluding words at the end, and may join in some of the open discussion at the top of the hour. But with that, let's turn to the three speakers that we have with us today. Each speaker will be responding to two discussion questions that we've discussed in advance, and I'll introduce them one at a time as I invite them to speak on the first question, which is really building from Montasser's opening comments. It's a question about what we've learned from the pandemic about the responsiveness of health systems for refugees and IDPs. It's really this question that did the experience of the pandemic, and whether we talk about the pandemic in the past tense is something we can discuss later, but has the experience of the pandemic, has it reinforced pre-existing health challenges? Has it introduced new health challenges, or both? What have we learned from the context and the experience of the pandemic? Our first speaker joins us from the Brack School of Public Health at Brack University in Bangladesh, Dr. Sabina Faiz Rashid. Dr. Rashid is the dean and a professor at the Brack School of Public Health. Her full biography is in the chat box. But she brings over 25 years of work experience in Bangladesh from her perspective as a medical anthropologist, looking at these questions of health in their broader political and societal context. So, Sabina, it's my pleasure to welcome you. You have the floor, please.
Thank you very much, James, and thank you, Montasser, for that introduction. So I'm just going to make a couple of points because I thought it's very important the way you posed the question, sort of pre-COVID and COVID, and what's really changed. So we have about 860,000 refugees that came to Bangladesh from Myanmar in 2017. It's one of the most largest and most densely populated camps. So you can put COVID into this mix. You can also put in other socioeconomic, cultural challenges. You can also assume a health systems that might be overwhelmed to begin with. But I'm not going to get into the standard, lack of facilities and human resource shortage. We have 5 hospitals for these camps, 33 plus camps, and about 630 beds. My main point is that luckily we haven't had as many deaths from COVID, at least reported deaths. It's been under 15. and about less than 1,000 cases, about 863 cases. But one thing that happened with the COVID was there was a complete shutdown, which meant all health facilities shut down, doctors were not available. But the reality is pre-COVID, many of the refugee populations prefer their local Burmese doctors, and they prefer drug sellers. So just having public health facilities is not enough. And I think we know that. And I think we're generously funded by 2 IDRC projects looking at the longer term sort of understanding communities' needs and how do we feed this into providers. So I want to bring in the linguistic and the cultural social factors that shape access, because even before COVID began, there was already an inherent reluctance to access facilities. So while men and women do go to facilities, first of all, women, as Montasser pointed out, need a male guardian if the facility is too far. But 2, if they can be convinced to go, usually it's the communities who are the roomers and validate or give you the experiences of other facilities. That, I mean, I pick a doctor based on what my friends recommend. I'm not sure why we think so differently just because they're refugees. They're not robots. They're human beings. They make choices and they make decisions that serve their own well-being. So that was one thing, that they already have a preference. The shutdown just reinforced you can't rely on these facilities. But when there was something a bit serious, or they were worried about something that had more, a potential to kind of need a surgery or some kind of hospital care, they would go to hospitals. But the first referral point is the localized providers. Very quickly, because I know we've got lack of time, is during COVID, our responses in many countries, including Bangladesh, was a very clinical response. Wear masks, wash your hands, and keep distance. You're talking to one of the most densely populated camps. 2, it doesn't resonate with your reality. It resonates with my reality because I live in a house and I have the privilege of having space and a roof over my head and a computer to do Zoom. These people, it's about survival. 2, the language of isolation and quarantine was problematic because of a very biomedical language with no cultural speak to the very refugees if we want them to access those services. So the stories we heard, because we're only in phase 1, is that I hear they're taking families away, or you might die alone. What does isolation mean? Why do they have to quarantine us? Maybe if we come back to our camps, everyone's going to think we have COVID. So a lot of stigma around quarantine and isolation. So this also reproduces and reinforces mistrust, because we have to remember they're in a country where they were forced out and persecuted in the first round from their own people. Then they come to Bangladesh where they speak a different language. So linguistic barriers, a fact of being misunderstood. And they always said in our interviews pre-COVID, even now with COVID, there's a lack of empathy. You don't explain to me. They don't give us time. So there's a whole notion of being made to feel inferior. So it's sort of this double marginalization, made to feel less than. We do that with the poor anyways, but being a refugee, this is exacerbated and magnified. If you're in a space where you're stateless, uncertainty prevails, and health systems somehow reproduce that through either the messaging or the way the facilities are set up, and the way that we don't actually try and reach out and engage with them to understand how do we even improve basic services, basic referrals, work with Burmese doctors, work with drug sellers. So that's some of my sort of initial points and thoughts. Thank you.
Terrific, Sabina. Thank you very much. I think the emphasis that you've placed on the mismatch between these, highly, the pathologized responses versus the notion of context and social relations, that mismatch. I saw Muzna and Weeam nodding their heads quite a bit within that. I think that's a theme that we'll be picking up on. So thank you for that. But let's now move to Weeam Hammoudeh, who is an assistant professor at the Institute of Community and Public Health at Birzeit University in the West Bank in Palestine. She teaches in the Masters of Public Health program and is the coordinator of the Mental Health Unit. Her bio will appear in the chat box in just a moment, but there it is. Weeam, the floor is yours, please.
Thank you, James. And thank you to everybody who was organizing. So I'll focus a bit on, what I'd like to say is, so the refugee and IDP population that we're mostly talking about in the West Bank they're not recent refugees. They're mostly refugees from 1948. So it's been over 70 years. But we still have about 30% of the of Palestinians living in the West Bank are still a registered refugee, and that number is higher in the Gaza Strip, where about 2/3 of the population are registered refugees. So we're talking about a context of chronic displacement. And not all refugees actually reside in the camps, but there are still about maybe 10 to 15% of the population actually resides in the refugee camps that are recognized by the United Nations Relief and Works Agency that was set up for Palestinian refugees in 1950. And I think this distinction is important because what we're talking about is also a population that's actually lived under conditions of chronic displacement, and there's been a lot of like also intergenerational displacement, intergenerational trauma that's been experienced, and there are also populations that are more targeted, I think, than other areas, especially in terms of like their exposure to political violence that's been still ongoing with the ongoing occupation in the West Bank and the Gaza Strip. And then in the areas where we also have a large registered refugee population, and these are internally displaced people that reside in what are called seam zone communities. So parts of their land have been confiscated by Israel either in 1948 or later on. And so they've lost access to large portions of their land. Some parts of their villages were taken from them, although they were not completely displaced as some of the other refugees that were coming from other areas that are now part of Israel. And so this is an important context because so the people living in these areas tend to be more marginalized, more exposed to political violence. But at the same time, there are institutions that have been serving these communities, and there are local organizations that have been serving these communities for the past 7 decades almost. And I think also Sabina's mention of it's not just COVID, but it's also largely in parts, it's not just the effect of COVID, but the effects of the closures that were very significant. So what we noticed in terms of like the way that what really had a big effect on people was just as a result of the closures, a lot of them lost work or could not actually, lost their source of income. There were issues around food insecurity that were heightened in some of these camps. And the living conditions generally are a lot more, so they're not living in tents, but they are living in like what looks more like urban slums. So the living conditions are more crowded with fewer rooms within the house. So isolation and quarantine are also not really possible as they might be possible, among middle-class urban people or even people living in villages. And so this was something that was already there before COVID, and this was something that was actually became more pronounced with the closures, with people not being able to reach their workplaces. And the closures initially also affected health facilities, even though UNRWA actually tried to keep health facilities open longer. And even at times where the public health facilities that the government runs were actually closed. And I think here it's really important to think about not just the official health system response, but the way that what we heard constantly about was the way that different local organizations actually came together. So you have different sets of local organizations, but what we really saw was there was like a big local initiative, because what we often heard was that the official organizations were slow to respond. They were still, as in other places in the world, they were still trying to figure out what was happening. They were slow to respond. And what we heard about was that there was like, people coming together locally where they actually set up checkpoints even though they were framed a bit differently at the gates, to make sure that people from outside the camps were not really coming in, to try to reduce some of the susceptibility, because they knew that if there was widespread, if there was widespread infection, it would be really bad. And so in that initial period, they also worked with facilities to be able to deliver, for example, medicines to people with chronic diseases. And so that came through coordination efforts. And what they also managed to do in some of these camps was, because even the facilities that are there, they don't actually they don't run throughout the day. So they close at about 2 o'clock. So there are no emergency services and other things. And so what they talked about was that they relied on volunteers from the camps themselves, who were health professionals, that actually used pre-existing structures to kind of put together and sort of like these ad hoc facilities and provide emergency services. There were hotlines that were actually created by local communities to respond to some of the needs, and they garnered support in that sense. But I think and so in terms of actually trying to provide alternatives to healthcare needs, they did a relatively good job of doing that, even given the limited resources and other resource constraints. But here it's also important, the structural factors in terms of like the socioeconomic impact started to have an effect. So even they were able to like maintain this kind of quarantine isolation and limit spread for a certain point of time, but in the absence of any sort of a sufficient social protection mechanisms, it eventually became like where they could not control the situation anymore. And what we ended up having was during the second and third phases of the pandemic, there were huge spikes in these refugee camps. And that was also where the shortcoming of some of these official organizations, whether it was UNRWA or like the Palestinian Authority, actually came into effect. So there was like an absence of quarantine centers. There was, in one camp, within 3 days, cases went from like about 3 confirmed cases to over 100. And in a lot of these camps, some of them had rates of about 20% of the camp population being confirmed COVID cases, where the actual numbers were much higher. And so what they were afraid of actually happened. And at the same time, they were facing pressures in terms of isolation and quarantine. And so you had, and what they did, and so this was where the systemic kind of marginalization of these camps actually came into play, and they were calling on officials to step in and play a more serious role. And what ended up happening was some like residents actually had to be moved like to hotels or other areas outside of these camps. And this remedied the situation to an extent, but the effects were still felt. And different people also talked about having to deal with like deaths or severe cases. And so these shortcomings were there. And what they kept emphasizing now, even though the situation in terms of like COVID has improved substantially, what became clear was the lack of infrastructure, especially in response to what the longer term needs or the more holistic public health needs of the camps actually became more evident. And what we're seeing now is that these local mobilizations in some camps are actually continuing and providing, for example, evening services for a larger for more health needs rather than just COVID. And so some of these are living on, but it really does vary from one camp to camp. So it is a difficult situation, but we are actually seeing very successful stories of local agency despite some of the resource constraints and challenges.
Thank you so much, Weeam. I appreciate that. There are 3 really critical points that I hear coming out of your intervention. You know, the first is to remind us all that where we have instances of displacement, that they aren't 2/3 of displaced populations in the world have been in exile either for generations, decades or generations. The average duration of a refugee situation is now more than 20 years. But if the situation of the displacement of Palestinians dating back to 1948, in the context of Rohingya in Bangladesh, what we saw in recent years was the 3rd time in my lifetime that we've seen a displacement of more than 250,000 people, these recurring situations. In the context of Syria, as we'll hear from Muzna, these highly contested contexts of internal displacement, which sort of fall very much between many of the gaps that we have in the international response system. But also, you know, this emphasis that you placed that it wasn't just the virus that posed concerns, but the responses and the impact of those responses, which really reinforces many of Sabina's points in terms of, you know, it's not just the clinical response, but the understanding that the social and political response. But the last point that you made, and here I'm going to ask my colleague Richard to put up in the chat box a link to the webinar that we had in December. I see that our dear friend and colleague Pascal Zigashane is with us in the audience from the Kakuma refugee camp in Kenya. And the points that have been made about the way that the community was really at the forefront of that response really echoes what we heard from Pascal in the webinar in December on the role of refugees in responding to that displacement when international actors were limited in their mobility and access. And I really commend you all to the work that Pascal is continuing to do in the Kakuma refugee camp. And that links in a very powerful way to Muzna Dureid and her intervention. Muzna has been a very active partner with LERRN since its inception in 2018. And she's been a very strong and powerful advocate for the inclusion of persons of forced displacement in the forming of policies and programs that affect them. Her full bio is there, but words don't do justice to the power that Muzna brings to the work that she does. She's the government liaison officer with the White Helmets within Syria, and joins us today from Montreal, having just gotten off the phone with the team within Syria. So Muzna, thank you for being with us. The floor is yours.
Good morning, everyone. Thank you, James and IDRC, for your distinguished invitation on this important topic. So after a decade of conflict in Syria, like we have in Northwest Syria, we have 40% of the health facilities and medical infrastructure have been destroyed systematically by the bombardments of the Syrian regime and its allies. Attacks have systematically targeted health workers and hospitals and left out 6 million internally displaced people without the basic health services. While WHO, the World Health Organization, recommended to have 5 doctors per 10,000 people, but in Northwest Syria, we have only 1 doctor per 10,000 people, and sometimes not, because like we have only 62 doctors in Northwest Syria for 6 million people. So, COVID-19 is exacerbating the risk on civilians because 40% of COVID cases are among the IDPs population, and because of the lack of basic possible measures to fight the virus, such as a social distance and water to washing hands, that makes like more difficult. Hence, COVID has both cons and pros, and I will start by pros to share positivity. So first, COVID obliged the donors to shift the status quo in dealing with the grassroots organization as a real partners by involving them from the designing stage till the implementing and later on ongoing learning stage. And that's because the travel restrictions, because no one could travel, so those grassroots already in place on the ground, so they are the best partners to deal with. And second, COVID-19 reinforced the peer learning methods among the grassroots organization and also with the international partners simply by having the access and the chance to attending important meetings, conferences, and also trainings, regardless or on where they are. And you know, like James, how Pascal from Kakuma camp has the opportunities to join us for like meetings of LERRN from the camp. So virtual space like gives us like the flexibility for displaced people to be at the table actually. And regarding COVID cones, so challenges to work in conflict zone during the pandemic would be like the bombardment, ongoing bombardments. We had a ceasefire in Syria for a year. This is the longest ceasefire we had in Syria, which lasts for 1 year and 2 months. And it's been just broken 1 month ago. And also disrupted supply chain, sanctions, limited resources, short-time funding, loss of our team members from both the pandemic and the bombardment, and also, yeah, sanctions on Syria by the banking system, which is like would make it's like very hard for us to deal with emergencies, and we have a delays with the banks for transactions. And yeah, just like last week, we lost one of our colleagues, the Ham, who has been killed by a systematic bombardment that targeted our center, and it destroyed it. So those also are like one of our ongoing challenges on the top with the pandemic. And through our gender-sensitive approach and people-centered approach, we designed a unique hijabi-friendly and female-sized PPE, personal protective equipment, to provide best response for women who are the most marginalized in the response, but at the same time, they are represent the majority of health workers on the ground. In addition, to control the spread of the virus, we integrated a waste management system by which we distributed 200 containers in northwest Syria to collect used PPE. Then by incinerator, we disposed them to contaminate the virus from used PPE. We at the White Helmets, as an IDP-led organization, had a quick shift to respond to the COVID-19 by our disinfection campaign for schools, hospitals, camps, and residential facilities. And also by our awareness campaign for civilians and for IDPs about which measures they could take to mitigate the risk of get the virus. And also by our service of bureau the death cases, because there's like a specific protocol for death cases of COVID to deal with, and we offer this service for the civilians. And also we produce oxygen locally in our centers. And we, like last September, we got a transformative direct funder from Humanitarian Grand Challenge, which is an organization in Toronto, in Canada, to ramp up our production because we shift our uniform manufacturing to produce PPE, and this funding is to ramp up our production. So we are serving now 10,000 direct beneficiaries who are the health and the humanitarian workers on the ground in Syria, and 4 million indirect beneficiaries who are the people of Idlib, one city in the northwest Syria, by producing monthly 1 million surgical masks, 48,000 gowns, and also 150,000 of shield masks for 8 months. And that also to provide like a protection for health and medical workers that like they are, because they are the most in need, because they are in a huge exposure with the virus.
Thank you very much, Muzna. It's a very powerful intervention. First of all, I remember very well when you testified before the Parliamentary Standing Committee on Citizenship and Immigration, and you brought the white helmet with you for your testimony. I think behind your intervention is a very powerful reminder of the individuals, your colleagues, who risk their lives every day for the work that they do. And my condolences for the loss of your colleague. I take away from your interventions two really important and powerful points. One is the technical ability for communities to be able to respond if the structures within which they respond can be responsive. So you mentioned the impact of border closures and sanctions and how that complicates and frustrates the work that you do, but even within that space, the responsiveness of the work that you've done, but how small changes like direct funding to organizations led by refugees, IDPs, how that has such a powerful transformative potential for the work of persons of first displacement-led organizations. But then I think the most important point, which really weaves through what we've heard from Sabina, what we've heard with Weeam, what we've heard from you, is the old adage that there are no humanitarian solutions to deeply political problems. And the responsiveness of local communities to be able to meet these health needs are no substitute for the very profound political will that's necessary to address the very causes of displacement. And as we see in all three of the cases that we're discussing today, that's something that we cannot lose sight of in our conversations. I'm going to pass things over to Montasser to guide us through the second round of discussion. In about 20 minutes, we will be turning to an open Q&A. I invite everyone in the audience, and we have a wonderfully strong audience with us today. Please do use the Q&A function or post your questions on Twitter using the hashtag #HealthForAll. I'll curate those questions and pose them to the moderators after our second round of discussion. Montasser, let me pass things to you, please.
Thanks so much, James. This was a really very powerful first round, and our speakers spoke very eloquently, kind of about the front line, from the front line, so to speak, about both the medical countermeasures and non-medical social countermeasures and the social context, and especially really the role of local leadership and the need for local leadership. So this really brings us to the second round to talk about sort of the localization aspects of this work. And I'll be inviting our speakers, panelists, to really speak about what does this experience tell us about the localization of health research and policy and practice beyond the pandemic, especially how solutions are designed, and about the agency of affected populations and local knowledge. Maybe we'll start with the same sequence like we had for the first round, maybe starting with Sabina, please.
Thank you very much. Yes, it's a lot of reflections when I heard from Weeam and from Muzna and also from you, Montasser and James. I was thinking about how we define health and well-being. And I was also thinking about refugees, because we have this one label, refugees, like we do for poor, like we do for conflicts. And I just wanted to unpack that more, because I guess I do research and I'm a medical anthropologist, but more just from life experiences. I would say that when we do research and when people talk about their health, what struck me was the heterogeneity and the kind of diverse experiences different groups, families, households, depending on how long they've been in a space, bring in these new spaces, right? With all the uncertainty and fears and resilience and mobilization. Because of course, like us, any other refugee has the capacity to be extremely pragmatic. And in fact, it's much more impingent on them to survive. So when you talk about health, and I look at COVID, and I think COVID just magnifies what's always been there. If you talk about racism, discrimination, politics, governance, social issues, refugees just get the worst end of the stick. In Bangladesh, it's sort of ironic because the host community, which is the Bengali community, there's a lot of tension between them and the refugees, because the refugees are seen as a group that's come from somewhere else. They're in these camps and they get relief, they get food, and they don't have to worry about hunger per se. But the reality is, if you unpack what health means, or health systems or health services, but if you start with the personal of the individual, the way they talked about their economic lives, and Weeam referred to this, where they talk about complete shutdown, loss of jobs, loss of income. And I was just thinking to myself, if I didn't have a job tomorrow, if I didn't have an income, how would I feel? So when, and it just made me think about, and then put on top of that, you're a refugee, you're a male refugee, or you're a male host family member who has to pay for food, who has to run a family. Many of them talked about emotional, mental anxiety and distress. Not only have a lot of the refugees who escaped been persecuted, I myself heard stories about, escaping all kinds of horrors, but also they come to a space where they're always treated less than. So, I mean, I don't want to go on too much about it, but I wanted to say health in itself is artificial. Our silo of biomedical is artificial. And no matter what we say about, yes, we have social determinants of health, structural determinants of health, COVID, the way we structure health facilities, our approach to the way we address facility discussions reminds me of how much more that remains, that needs to be done, even in terms of the way donors and development partners, service delivery, researchers, implementers, policymakers need to reframe and understand what health means. Because for many of these refugees and even the host communities, because they're very poor, economic loss, food consumption down, even the refugees that did get food, they talked about inadequate portions because the government in itself is struggling. And I have to admit that the government's trying to do a good job as much as possible. Then you have a lot of mental, emotional anxiety, day laborers, refugees were doing small, odd jobs to earn a little bit more money, to have some freedom, to make decisions, to be stateless and then just live in camps. It's really, really very, 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 I would say it's unbearable. Then you have a cycle of deaths. So you had a lot of host local community members who liked the refugees because they worked with them, worked for them for cheaper labor. So it's economics. At the same time, the host communities would talk about a cycle of debt. Then they talked about mental health. But finally, I guess my point is localization, empowerment. And I would just say that, even if we take a step back from localization, I'm not meaning to sound academic, but I think what are our values? Like, IDRC has funded us, we're doing research. Yes, political commitment's important. But how about we take it a step back and take it to the individual level? I, as a researcher, you as an implementer, or you as a funder, or you as a health service person, how do we view, treat, value a person who comes from a refugee background? Because I think the fundamental is human dignity and respect. Because if you provide an individual with respect and dignity, that improves one's well-being. They're treated as human. We've dehumanized poor people. We've dehumanized refugees because each one of us wants, I don't want to sound preachy, but I've thought about this a lot, and it affects the work I do. But I do think fundamentally, dignity and respect is the starting point in terms of our curricula, what we teach in public health, in terms of the research we do. So how about we design tools talking to young women in the camps, talking to men, talking to leaders, not tokenism, come here, we'll work at you, objectify you, work with you, challenge our questions. Are we asking the right questions? Are these your priorities? Are these your needs? Often interventions will be set up and then it'll be like, oh, they're not compliant. There's no uptake. Oh, they don't understand, more education. I've actually found, I've been in Bangladesh since 93. I was in my 20s, I'm 51 now. They're extremely pragmatic. People are very vulnerable and they're actually really smart and they have the best ideas in the constraints they have. So I would say that the politics is important. The global governance is important. But while we wait for conflict and wars and people to improve and have better ideas and better politics, how about we start with better research that values the human dignity of the refugee? The practitioner or implementer doesn't come from a beneficiary model. I am the savior and I am going to help you. How about I need to work with you and I need to learn from you and I need humility in terms of what we can do to improve your lives, but I don't want to make it worse and we have limited resources. So I think the starting point comes back to even me, my responsibility if I'm going to do the work. It's hard, it's challenging, I agree. But I think it's good to have these critical reflections because if COVID is not the time, I don't know when is the time to have these critical reflections on paradigms that exist and what we can do. Otherwise, we go back to, I was in a meeting yesterday, and I'll shut up in about a minute, James, because I know you're having to moderate time. Is that we go back to governance and politics. But I just sometimes think, what about what am I teaching our students about human dignity and life and values? What are we doing in terms of research that actually, what Montasser you're saying, co-produces, generates truly co-produce evidence for policymakers? It might be idealistic, it might be not feasible immediately, but it's a step-by-step process. And that creates a certain space. When you provide respect and dignity, it creates a space for ownership and engagement. So health, I want to say, needs to be understood more broadly, not biomedically, because our whole lives are shaped by so many different factors. And I think it goes back to our fundamental values in the fields we work in, which means, you know, in different ways that we can address this. Thank you very much. Yeah.
Thank you so much, Sabina. This is very, really poignant what you're saying in terms of, first, in terms of that all this work needs to be driven by values and human value and valuing human life, but also other values of ethics, fairness, equity, and inclusion. Also, you mentioned about the, you know, really trying to be always conscious of the diversity of the refugee, you know, what we, as you said, you know, that category of refugee or displaced populations. There's such a diversity, age, ethnicity, gender, sex, you know, like there's just a whole number of diversities that when ignored is really problematic. And then of course there is the value or the importance of having some coherence in all of this and the responses, you know, so as you say, like, you know, one hand doesn't know what the other one is doing, and everyone thinks that they are necessarily doing the right thing. You've raised so many points, but I will not recap them because that's not that's impossible. But I will just go on maybe to ask Weeam to speak next and to maybe build on what you have already mentioned, Sabina. Weeam.
Thanks, Montasser, and thank you, Sabina, because I think Sabina covered a lot of the important points, and it reminded me of one of the interviews we were doing with a head of a local committee in one of the camps, and he was like, I mean, one of the points that he kept emphasizing was, you know, people think of the camps as these areas where we're just recipients of charity and kind of, and this is sort of how we deal with it, but nobody actually asks the question of why are we still here after 70 years? Why is this condition, you know, ongoing? And I think this does raise important points. It also raises important points about, yeah, like there, you know, there is a need to understand the context. There is a need to like understand how things are actually manifested locally, how people actually experience things. And what we see is like, especially, you know, I mean, and maybe again, like the situation here is a bit different in terms of the duration of displacement. And so you do have institutions that are kind of, at this point, very bureaucratic, very sort of well established, but at the same time, there isn't a lot of flexibility in terms of how they actually even respond to the populations. The discourse hasn't changed all that much in terms of, and we still see it today. Like, I mean, and I'm saying this while also acknowledging the important role that they do play in actually providing basic services, but at the same time, how long can we actually continue to frame the refugee issue as this issue, as a humanitarian issue that's in need of, you know, food aid and medical assistance and whatnot, especially when we're talking about now 4 generations of refugees. And I think this is a really important point, and this is also a really important point, not in just in terms of like how we frame things academically, but what kind of work are we actually doing, and what kind of advocacy are we also calling for? Like, are we calling for more aid? Are we calling for just providing assistance that people will continue to rely on for another 70 years? Or are we actually calling for structural change that works with communities and also works with justice in mind and accountability in mind for researchers and for practitioners? And I think this is a really important point. The other point I did want to touch upon is this whole issue of agency, and it is connected, because when we're talking about refugees, and I think what Sabina said also about the importance of unpacking what that term means and how it actually, there's a lot of diversity of experiences that falls under this this label of refugees or internally displaced people. We forget that there is agency there as well, that they do have a lot of knowledge, oftentimes more than, you know, they know more about we know about their needs. They also know how to and they know how to respond to these needs. So, and I think, and this frustration was also obvious in some of the conversations that we were actually having with people. And we are like at the early stages where we're still trying to understand, but it's also, you know, and they would talk about, for example, like the health facilities. They're like, yeah, okay, they provide medicine for diabetes, for whatever, but they're not actually addressing our core needs. They're the times that they're open are just, you know, from until like, let's say 2 o'clock, they're not open on weekends. They're not providing things beyond that. And this is still within the frame of the limited biomedical. And then if you want to actually expand it to think about like well-being and health, you really do need to address the structural factors. And it's important to also think about like what subpopulations also get ignored. Like one of the populations whose needs were not met, or whose, you know, who actually I think was maybe even more affected during this pandemic and with the closures are people, for example, with disabilities and rehabilitation services, physical therapy. That was something that was closed. And I mean, until now, they're not like operating at full capacity. Women that were also facing a lot of additional pressures just with everybody being at home, living in spaces that are already confined and where their movement is already more restricted than men. Like one of the things, we had a visit last week, and there was a lot of remarkable work that was actually done in this camp in the south of the West Bank. But one of the things that they noted was, like, for example, if you look at the emergency committees and the response, there wasn't really there wasn't a strong presence of women. And it's not, and they recognize that this wasn't because women didn't have the capacity, but it's just given the constraints, they're not going to be the ones like standing in the streets at night, trying, you know, making sure that people were adhering to protocols and whatnot. And they recognize, they're like, you know, there are needs that we're not going to be able to address unless women are actually given more space to participate. But even within that, you know, and I think it was actually really important that there was that recognition. They didn't need somebody outside coming to tell them, oh, they should be there or whatnot. And they found some alternatives, and they're still continuing on to like it reinvigorated something in people. It reinvigorated sort of this whole idea of local mobilization. It reminded them of days that they were days of the past, especially with some of the political and social changes that have been happening. And I think this is also something that we need to remember as researchers, and I think it's also something that we need to remember as practitioners, is that there needs to be also a bit of humility. We don't have all the answers. There's a lot that we can learn, and I think it's really important to actually have the starting point be, what do you actually need? What role, if any, do you see for us in this, without necessarily trying to take ownership over or even credit over the work that's done. And I think I'll stop at this point for now.
Thanks so much, Weeam. You compressed so many really important points in a very short intervention. So thank you so much for this. I'll just highlight a couple of things that stood out for me. Really sort of that the equating of humanitarian responses with charity, kind of it's as if it's a one-way street. This is kind of a very, of course, old-fashioned sort of imperialist model, maybe one can even say. And of course, we all see the need for that to change and at least to be challenged. Also, you really raised a very important point, I think, in sort of contrast to my earlier comment about sort of the short-termism, is that, you know, the challenge of the longer-term kind of responses sometimes is that they are calcified and inflexible, that they're actually not keeping up with the changes in populations and needs of different segments of the society, and then of the refugee population. And of course, you raised some really important points about gender issues as well. And these are all really just very well taken. Thanks so much, Weeam. Maybe now quickly we turn to Muzna to give the last kind of intervention in response to this question. Muzna.
Yeah, thank you, Montasser. It's really hard to speaking after Sabina and Weeam. So COVID tell us that status quo should no longer considered as a solution or a possible option at the table. After what we went through globally and locally with the pandemic, the one-fits-all response and to fill in approach will waste our energy, funding, times, and will not drive us to put an end to the suffering or to meet the needs of people by a sustainable solution. Localizing the response across actors is not anymore a secondary asset, it's an essential pillar. And the White Helmets as an IDP-led organization, we have a unique perspective of survivors with relevant expertise based on the knowledge of creating a strong sense of survivorship locally, statewide, and globally. The team is a safety valve as a first responder and essential players to stabilize Syria by helping local people to regain and rebuild their lives during ongoing and post-conflict. When the pandemic hit our world and after the border closure and the supply chain have been disrupted, we shift our uniform manufacturing very quickly to produce PPE because we noticed that we have shortage in PPE to save lives of the few doctors and health workers we have in Northwest Syria from COVID. This shift happened because of our people-centered approach, mutual trust, ongoing conversation with donors like before and after and during the implementing the projects, and also decolonized co-partnership. Capabilities are already existing, and the most rapid and effective response come from and within local communities themselves. Bold ideas and solutions are already on the ground, waiting for incubators, academics, and donors to shift the paradigm, especially in making grants. And an innovative solution come if donors put extra efforts to support grassroots organization rather than only reaching white passive actors, although by avoiding business as usual policies. COVID-19 proved the need for long-term direct funding for IDPs and local initiatives organization. And the long investment in grassroots organization is about to put the money of taxpayers in the right direction to help the most in need. Half-baked solution arguably failed, and reaching the hardest to reach should be the center of any public work. We need to remember that democracy is built on the human rights principles at the first, like when we creating democracy. And finally, response is driven either by leadership or by crisis. And it's better for all of us to pick leadership to get optimal outputs rather than interacting with the crises that are out of control. And despite the odds, the White Helmets succeeds to create local cutting-edge PPE manufacturing in Northwest Syria locally, totally, like 100% locally, in the area that stuck in people's mind as a dead area. And this is, for me, having access for PPE, it's really challenging even for Western governments. So this is how we're shifting dead areas for producing and PPE in during the pandemic and conflict in the same time. I'm done speaking. Thank you.
Thanks so much, Muzna. You said you didn't have much to add to Sabina and Weeam, but you really added some very important points, especially about sort of the being people-centered and being community-driven, grassroots, and demonstrating how that this is the shortest way to success, is to really have the resources directly managed by local communities of IDPs. As you were speaking also, Muzna, you kind of raised for me kind of like really the challenge that we all have, and sort of like translating the kind of the bureaucratic language of, stabilization, rebuilding, post-conflict, but really having that more humanized and rights-based. What does it mean for people and potential and the situation under these terms or these expressions where people live, and then what are their aspirations, and starting from the capabilities they already have to rebuild, to restabilize by themselves, and where the external effort is nurturing, supporting, and lending hand where it's needed, but it's the leadership that comes from within. I could go on and on, but I think there are also the audiences who have some questions and want to add their own reflections probably. So I'll turn it back to James, but sincere thanks to the speakers.
Thank you very much, Montasser, and don't go away, because feel free to jump in with the questions we've received, and it really, the point that you made, Muzna, about how the privilege that we have of being able to gather in these virtual spaces means that we're able to bring new voices in. The Economist had a piece not that long ago about the potential of virtual diplomacy, and whether we build on that as a way not only of making sure that these perspectives are brought into global conversations, but also breaking down the barriers between these different sectors and the sometimes the incoherence between these responses. There was a question we received in the Q&A box, and 2 points that have come up on Twitter that I want to curate together in a series of questions to put back to the three of you, and Montasser, feel free to jump in on this point as well. I'm delighted that Abeid, our colleague from Redeso, a national organization in Tanzania and a member of LERRN's Tanzania Working Group, is with us on the line from Tanzania, and he in the Q&A box really asked the question to the three of you from the context of Bangladesh, from Palestine, and from the context of Syria. In the context of Tanzania, national civil society organizations have long been trying to not make the point, but reclaim the history of having been the leaders in responses to displacement and humanitarian situations. And so the question from Abeid from Redeso in Tanzania is really, are there lessons that you can point to of where you've been successful in advocating for greater humility on the part of international actors, in actually making real some of the rhetorical commitments around localization? Are there any successes or strategies that you might be able to share? This links in well, pardon me, this links in well with a question that was posed on Twitter, or a reflection on Twitter, which is really this disconnect between the local and the global. And what we've been hearing from all three of the contexts is the real power of knowledge and expertise, and that is to be to be appreciated from within these contexts. But how a more conscious or successful effort, however we define success, but if there are ways to bring this experience into conversation with discussions at the global level, what would that do in terms of legitimacy? What would that do in terms of accountability? And in very crass terms, what would that do in terms of effectiveness? The point was made on Twitter that last week, donors pledged over $1.2 billion to support the response to the Venezuelan displacement within the region. And despite calls for a portion of that to go directly into organizations led by local communities, led by persons of a displacement experience, that the $1.2 billion going through these traditional chains. And so how do we arrest, how do we change that kind of dynamic? And then the last point I would raise, Sabina, I think it's really animated by the point that you made about sort of shifting the paradigm towards a focus on decency and respect. A point on Twitter said, how relevant is this concept of resilience? Something that came up in the discussion on host community responses in the context of Lebanon earlier in our series, that colleagues in the context of Lebanon said, we're sick and tired of being referred to as being resilient. It's time to recognize that you can't just ask host communities and affected communities to be increasingly resilient and to address and invest in resilience. Instead, it's time to shift the paradigm and realize that, for decades we've placed an emphasis on resilience and international responses. If anything, we've built up this international humanitarian infrastructure and system. How do we shift that paradigm? It's an impossible question to ask you to engage with, but with these questions of what are the lessons of success around localization? How do we address this disconnect between the local and the global when it comes to enhancing the legitimacy, accountability, and effectiveness of the tools that we have? And then finally, how do we wrestle with this concept of resilience? I'm going to look to the three of you, and Sabina, you gave me a shrug, so I'll take that.
I'll go first. Might
Go
as
ahead.
well, huh? So I was just thinking about successes, and Bangladesh in itself has some successes in terms of public health advances, and it's because of its integrated approach and very, very sort of community engagement at every level. And this was taken forward by civil society, NGOs, some very large-scale NGOs like BRAC, working with government. So we have some history of success. International and refugees, we're still in the nascent. I would still say we're in quite early stages in trying to understand the Rohingya camps. It's very politicized. There's a lot of monitoring. There is still a lack of, the same thing with actually internally displaced populations in informal settlements. There is no comprehensive urban policy because the government is scared they'll never go back to the villages. Same with the camps. So I find with, I don't know, maybe I'm coming from a space where we just experienced 87% cuts to budgets from the UK government. I also saw during COVID, many global buyers just didn't pay LMIC countries that had orders ready, and there was no global governance or accountability or justice, because who's going to speak up about on behalf of whom? So I don't want to be presumptuous, or maybe I'm just coming from a particular space of seeing budget cuts where there was a lot of community-based engagements that just got removed like that. Where if we're talking about values, ethics, sustainability, or commitment, what does that mean, right? So I can't speak for IDRC. We've been, we're doing research, we've been funded, and it's very, I'll have to say one thing, IDRC, and it's like a few donors I've worked with or funders, it's very locally driven. So even when we do our prioritizing of what's important in our context when we do research, and I'm not saying it's just because we're entirely self-funded, the luxury of actually saying we want to work in our own space and contextualize the problems, the challenges, and priorities, it's a huge luxury in the work we do. So that, I have to say, IDRC allows us to do. What I would say is we need to take it to the next step and ensure communities are very much engaged in that process. I don't know if I'm answering those questions correctly. In terms of resilience, I got into an argument with a journalist. This was an expatriate journalist who talked about the brave young men in informal settlements. So I said, I have a problem with the language of brave, but I also was in a dilemma because I didn't want someone to make out they're always victims, everyone's suffering, a very homogenized picture of doom and gloom, because there is a lot of the spirit of just continuing for survival's sake. So I said, can we not say brave? We were having a conversation because it makes everyone else seem like a coward. Can we use another term that kind of has something, more nuanced? Because the spaces that people who live in, whether they're in camps or informal settlements, are very messy spaces. And it's sort of multiple risks and vulnerabilities, and it's constantly shifting. And the fluidity of poverty and vulnerability within vulnerabilities is shifting. So yes, I wouldn't say no, we don't need to say resilience. I wouldn't say you don't mention it at all. I think resilience is important because if they didn't have resilience, we have, you know, I mean, in general, I mean, I think we have to recognize that, but qualify that very clearly with how much longer and what do we mean by this resilience? And is it fair? And does it use a social justice perspective on rights and agency? And do we humanize or dehumanize the groups that we say resilience? Because it's convenient to say resilience in certain kinds of politics. So I think we have to understand the politics of those statements and the context of how it's being used. That's my comments, really, because otherwise other groups, we label, and when we live very comfortably in that. And I think we shouldn't just remove labels either. Labels of resilience are not necessarily negative, but they can also create a space where, oh, look, it's like, look at that. I remember just one final comment, because I know we're wrapping up, is this Aboriginal runner I studied in Australia, a family there, and they went on and on about what a great runner she was. And some of us had got into a debate because we said, okay, so every Aboriginal, irrespective of their life experiences and persecution and political sort of extermination, has to be this brave Kathy Freeman. I mean, I think that's really, really social injustice. It's language being used to kind of deny and invisibilize other forms of oppression. So I think that's the way I'd respond to it. Sorry, a bit complicated. Yeah. Thank you.
No. And I think it's we can't, you know, my intention in this is not to tie a neat and tidy bow around all of this as we wrap it up. I think that this really, you know, this is a very powerful way to be, you know, within this webinar, to be concluding this series, is to say, you know, that it is intensely political, it's profoundly messy, and that we can't shy away from that messiness. That there's a lot of comfort that I think gets derived from these bureaucratic labels. I think of Roger Zetter's work from 1991. I mean, gosh, that's what, 30 years ago that we've known about the way that labels are really necessary for bureaucracies to function, but they efface so many subtleties and nuances across personal experiences. But also the functioning of those labels come to form these real sites of contestation. And so if we aren't aware of the intensely political realities of the functioning of labels, you know, that we become very complicit in the perpetuation of the kind of status quo that I think everyone has called on us.
Yeah, sorry, Jane. I was going to say, even myself, I have to have a critical, it's reflexivity of my role in how do we perpetuate, challenge, critique, and have these debates, because the world is not going to change overnight. COVID has shown shortage of vaccines. It's shown ongoing wars, has shown the have-nots and the ones who do have. I mean, I'm privileged. I live in Bangladesh. There's a bunch, there's a huge shortage now. That, you know, so I just think it requires a lot of reflexivity, and that doesn't mean we can't have these discussions. I think discussions are powerful way of creating and shaping minds, young people's minds, and everyone, you know, and each other's minds. So yeah, I'm honored to be part of these discussions. So thank you.
No, yeah. Thank you very much, Sabina. Muzna or Weeam, who would like to go next with their reflections on these points? Muzna reached for her mute button first, so in the global speak of Zoom, Muzna, that gives you the floor. Muzna, over to you, and then Weeam will turn to you for your reflections before we turn to Montasser for some concluding comments, and then I'll wrap us up by the half hour. So Muzna, over to you, please.
Yeah, thank you so much. Thank you, Abed, for your question. I feel you, actually. But I have 4 points, from my experience, which is first, we need and you need to keep our ongoing conversation with donors and international actors, to keep asking, knocking doors. I know sometimes it's disappointing, overwhelming, and we have a huge setup problem that we need to deal with, but still, we need to keep it, because sometimes in our project for PPE manufacturing, so it came by a private invitation of call for funding, and it came because I had a conversation with the organization, with the donor before, about what we are doing and what's the problem that we have and what we need to to do. So this is the point one. Point two, it's like to create a coalition and cooperation between a grassroots organization. It's like to enhance the peer learning between us, and second, also to fill the gap in our capacity. For example, if your organization has like a less capacity than other one in finance, for example, you can create a coalition or like a cooperation with other grassroots organization to apply together to any opportunity. Third, it's like to offer for the donor cost-benefit calculation. You will be shocked that even donors, they don't have a full image about cost-benefit calculation if they go with us or like with the grassroots organization, or if they stay with the business as usual policies. And just like to give you an example also, WHO has elected the Syrian government, the Syrian regime, as a member of a community, like a board committee of the WHO. And we keep like sending messages for WHO, the World Health Organization, why you are selecting the Syrian government as a member in your board committee. Is it like their mandate to advise you how to attack hospitals, how to attack civilians and health workers? So you need to put all cost benefit all the time calculation for them. And also about the corruptions, like dealing with the corrupted governments, especially like in Lebanon, in Syria. This is like they feeding the corruption by a way, and they need to avoid any kind of collaboration with corrupted governments and shift it to grassroots organization. Fourth, and this is for you personally, anger is good for the cause and is good for the work, but it's damaging ourselves like over time. And like I feel like now after 10 years of the conflict, after a decade, the anger that motivates me to change things around me, it was super good, but it's very damaging for myself, for my health, for my mental health, and so on. So we need to keep angry, but in a way that's not damaging us. And I'm done speaking. Thank you.
Thank you very much for that candor. And I'll say something at the end of the webinar about what a privilege it is, the trust that our speakers, not only in this webinar but throughout the series, the trust and the confidence that so many speakers have shown in sharing so candidly. And I think that point, Muzna, about it comes back to the question of resilience. That resilience becomes a very convenient excuse for not addressing, the fundamental questions of politics and the drivers of displacement. That if we keep expecting more of the communities themselves to be increasingly resilient, the point that you made, 10 years of anger takes its toll, and whether that's a just expectation. And with that, it's something that was very much on my mind as you were saying that, about recent events in Palestine, and after 7 decades of anger and displacement, how much more can be expected, how much more water can be squeezed from a stone, so to speak. And so, Weeam, let me give you the last word on some of these questions before I turn it over to Montasser. So, Weeam, the floor is yours, please.
Thank you. And again, I think a lot has been covered, but maybe to pick up on that point about resilience, and I think this is something also as a Palestinian, it's something that's been reiterated constantly. And sometimes what that does is it kind of, there is this contradiction, right? Like there's, you talk about refugees, you talk about displaced people, oftentimes they are, if we go back to this framing as victims, as people who are in need of this humanitarianism and whatnot, but then at the same time, we are expecting them to have resilience and this kind of almost superhuman quality, and this is often the case, especially when talking about Palestinians. We saw it also with the last, with the most recent events, like throughout Palestine, but especially like in Gaza and in Jerusalem. So, and I think that always runs the risk of doing a disservice, because at the end of the day, we are not these superhumans that can just take everything that comes at us, right? In the literature, these studies also focusing on like the allostatic load and what that does eventually, the wear and tear in the body, and how that over time that actually affects people's, not just their well-being, but also their physical health over time, even though the effects might not be seen immediately. But it also, and I think, and then there is this other danger that I constantly worry about, because oftentimes we are trying to push the conversations, we're trying to shift the paradigms. Sometimes when that shift in paradigm, or like at least like on a discursive level, is picked up by some of these international organizations and whatnot, they sometimes become detached from meaning or decontextualized in a way that and I think even the use is very political, even though it is depoliticized in important ways. So when we're talking about now, you see it, especially like in a lot of the work that's on mental health, it's like, okay, so why don't we think of interventions that focus on building resilience? But then when you actually look at the details, what does it actually do? It's like, let's try to figure out what kind of individual characteristics we can work on to build resilience for people to cope with what's being thrown at them, instead of trying to address what's actually being thrown at them and why it's being thrown at them. And it becomes almost as if it's like a personal trait or personal feature without affecting any of the structural issues, or without even acknowledging them sometimes, right? And I think this is where that accountability needs to be translated into it. It's not enough for the language to be picked up, right? It needs to come with questions about accountability, with discussions about how and to what extent are we actually replicating these cycles? To what extent are we also playing a role in allowing that conversation to shift from one of social justice to one of sort of like just kind of putting band-aids on some of these issues? Do the kids in Gaza need to learn how to do yoga on the beach to relax, or do they need bombings to stop? And this sounds ridiculous, but this, if you actually look at how some of these interventions are phrased, it's there. And it's that kind of depoliticization, it's that kind of also using language in a way where it becomes devoid of sort of the politics and issues of accountability. You run that risk. And in the long term, I think that could even have worse effects, because the cycle continues without any real accountability and responsibility. And that's why it's really important to actually pay attention to these things, and to what kinds of interventions and what kinds of things we can actually advocate for when we are attached to some of this language.
Thank you very much, Weeam. I think that's just such an important way, not to try and end the conversation, but to recognize this is a conversation that can't be contained within 90 minutes. And so, Montasser, let me turn things over to you for your comments, and I'll then say a few words of where we hope to go next within this conversation, and some words of thanks before we conclude. Montasser, over to you, please.
Thanks so much, James, and I'll be very brief because I know we're just a minute already over time. I really want to thank you, all our speakers today, and our listeners and participants very much for joining this session today. Really, I learned a lot, and it was a great opportunity to hear really from the front line what the experiences are of people and of people trying to help people. So this is really just all about human connection, human concern, and human work, humanistic work. The speakers today spoke to us about the importance of establishing trusted relationships with both affected populations and decision makers, and how also research can play a key role in filling knowledge gaps, both in the short term and the long term. And this is something, of course, research is something very deeply close to our work mission and what we want to see more of. The shared experiences about how research can play a role and to understand differential needs, support more inclusive and gender equal responses and recovery, it cannot really be overemphasized. All this seems very complex, as you said, James, cannot be contained in 90 minutes, cannot be solved in a day. So it all seems complex, urgent, and sometimes overwhelming. But I think we should still resist the urge to rush to quick, pre-packaged, and one-size-fits-all fixes. I think all our speakers spoke to that very eloquently. Each country has to find, country, community, they have to, and collection need to find their own pathway, and examples can provide sources of reflection and inspiration about how decisions need to be made and by whom, and who really is in control of the resources and the solutions. I'll end here with sincere thanks and wish to continue our collective engagement in these issues in the future. Thank you.
Yeah, thank you very much, Montasser. And I think that's probably the most appropriate place to end is not with a conclusion, but a commitment to continue. And certainly from the perspective of LERRN, you know, our voice is not, our role is not to amplify the voices of researchers that have dominated the literature for so long, but to amplify those voices that have often been marginalized and displaced. And so I'd like to reflect on my own privilege to sit comfortably in my basement in a bungalow in Ottawa with electricity and running water and relatively reliable internet, and to reflect. I think, Muzna, the point that you made on what does it mean to put into action a commitment to be an ally, to help push so that these perspectives and these discomforts, the imperfection, the politics of these labels and these categories, that we continue to challenge them. But I think more than anything, it's to reflect on how privileged I have been, in this webinar, but in all the webinars that we have had, how our speakers have shared so candidly and so fully. We can't ignore in the environmental space, we talk about the inconvenient truth. I mean, what we have seen through this webinar series is just how imperfect the status quo is, and how how urgent the need is to do, Muzna, as you said, the peer learning in terms of how we take these practical steps towards challenging the status quo and listening to the knowledge, the expertise, the perspective that's going to give us a foundation to bring about change. So to you, Sabina, to Weeam, to Muzna, thank you for your perspectives. Montasser, thank you for co-moderating and bringing your perspective and expertise on this. Thank you to the audience that have joined us from more than 20 countries from around the world. It's wonderful to see how we're able to sustain these audiences from the Kakuma refugee camp in Kenya, from Tanzania, colleagues joining across time zones and across spaces. I ask everyone to please stay tuned, that LERRN is considering how we can continue to make use of this virtual platform to continue these kinds of conversations in the next academic year here in North America. So starting again in September, details will be circulated very soon. This is the last webinar in a series, and so I would like to say a very special word of thanks to my dear colleague Rula El-Rifai at IDRC, who has been such an incredible colleague and champion of these issues, to Montasser and to all of the co-moderators throughout this series with the perspective that you have brought. I want to say how enthused I am with IDRC's engagement with these issues, with the call for research chairs on forced displacement in East Africa and the Middle East, and this commitment to be a leader in the localization of knowledge on forced displacement issues, and to challenge the very concept of what constitutes knowledge. I look forward to continuing this collaboration. To the LERRN team, who through incredible circumstances has done extraordinary work, to Nadia, Tyler, Rachel, Rowan, Stephanie, Sahila, to everyone who's produced the reports and made it work. A special thanks to Richard and Stephanie Hubert, who've managed all of the technical glitches with grace and with ease. A very special thanks to Nadia Ismaeva and to Jennifer Kanji, who have done just a tremendous job in coordinating the practicalities and making sure that this is not just a performative series, but one that really tries to ask those uncomfortable and those awkward questions. So this ends the series, the LERRN-IDRC Webinar Series. You will receive a survey. Please complete that to tell us what you thought of the series and of the webinar today. A profound thanks again, Sabina, Weeam, Muzna, Montasser. Wherever you are, wherever you're tuning in from, please stay safe and stay well. And we look forward to continuing this conversation in a couple of months' time. Take good care, everyone. Thank you very much. Bye-bye.
Thank you, everyone. Thank you, James, so much. Thank you, everyone. Thank you. Bye-bye.